Hello and welcome to this brief overview of clinical photography. Before starting, I'd just like to tell you a little bit about myself. My name is Ian Hutchinson and I qualified from the University of Newcastle upon Tyne, which is approximately 4 hours north of London. And I can thoroughly recommend people go and visit Newcastle for its unique culture and beer. I'm a registered specialist in orthodontics and I have an interest particularly in lingual orthodontics. I serve on the committee of the British Lingual Orthodontic Society and help run courses and give presentations not only in the UK but at various other locations throughout Europe. I have an out-of-town office, and here we can see the patient's lounge. On the lower left we can see the teaching room behind the glass partition, and in the lower right we can see my surgery. Now, returning back to clinical photography, what we'd like to discuss in this session is why you need to take images. I'd like to go through some technical terms to take out the mystery that's often associated with clinical photography. I'd like to go through what you need to do to make it easy for you to take good quality images and how to, and also just touch upon some frequent errors which many people tend to fall into the habit of. Now, why take images? What I have found is that once you understand photography, it starts to affect your personal photographs. For example, your holidays. So here, it wasn't actually a holiday, I was on a course. We're outside the casino in Monte Carlo. And we've been playing with the aperture and the shutter speed to capture the droplets of the water from the fountain, as well as keeping the casino in the background in focus. And like we've mentioned, you get so sort of involved with photography, you can't help carrying a camera with you for those one-off times. Although these days, with the advent of camera phones, it's a bit less clutter to carry. Now, you could say this is debatable, but it does seem to hold true, in that good quality photographs are reflected in the quality or standard of your clinical treatment. And also, why else take pictures? Well, often it's easier to explain to patients what they will need to have done, what their treatment is, and what the expected outcome can be like. So keeping a portfolio of your work, whether it be in a printed book, or for the younger generation patients, they seem to like digital media, so an iPad, for example, can help explain what they need and what they can look at the end. It also helps communication with our colleagues. So in this lingual case, the brackets were positioned using the best technique, bonding with equal specific thickness. Now, to do this, we need two bits of equipment: a BPD, bracket positioning device, and a TAD, torque angulation device. Now, I received the lab work from the technician, bonded the brackets, and this is what they looked like. Now, he was adamant they were in the correct position, but it's obvious to see the heights are all different. And as we found out, he'd actually only got the torque angulation device. So we had to explain to him why you needed both bits of equipment and the photograph to help highlight the problems and why you should buy the equipment. Oral pathology, white lesions, red lesions. Clinical photography can help monitor the situation, but also slightly unusual incidences or occurrences. For example, here's a case, and if you look, you can just pick up the subtle erythema around the lips. This patient was allergic, not to nickel or chrome, not to latex, but to actually composite resin. So there are incidents of people being allergic to composite resin. And again, taking photographs, we can communicate with the dermatologist and arrange for patch testing, etc. Other reasons to take clinical images is to help show or educate the patient that their treatment is working. One of the, well, I wouldn't call it a problem, but with orthodontics, everything is very slow, and the patient looks at their teeth every day. So small increments aren't as noticeable as large jumps. So if we take photographs, it can help show, for example here, the space we've created by using a mini screw and spring to open space for the impacted premolar. So not only can we help teach our patients, but we can help teach colleagues. So here's a patient who came for correction of a crossbite. She'd seen several other people who said it wasn't possible. And we can see from this image, we can't simply procline the teeth because the angulation would be too great. We need some intrusion, as we can see from the gingival margin heights, and proclination. And we'd achieve this by simply using a mini screw, temporary anchorage device, and a little bit of elastic. The force is in front of the centre of resistance of the teeth, so as they intrude, we've also created a counterclockwise moment and they jump the bite. So taking photographs can come in useful for a whole range of different possibilities. And another one would be patient motivation. So the patient who doesn't brush the teeth, obviously we can use disclosure tablets to stain the plaque and help identify the bits that they've missed. And if they don't clean the teeth, we can show them what's likely to happen. Demineralization, white spots, dark spots. And also in the treatment planning stage. Here we had to inform the patient we'd have to undertake some slenderization of the central incisor. The patient wasn't quite sure why until we took the photograph, and then we could actually measure it and they could take ownership, as it were, and understand. But this is what we also send to our patients. I routinely take photographs and basically do a digital smile design, Christian Coachman, well worth seeing, which shows how the gingival margins need to move, the smile curve, and it's just a way of helping sell. If you can educate the patient, they can take ownership and therefore more prepared to do something because they can understand the problem as opposed to you talking at them. And here we can see some simple outlines to help show the ideal tooth size, tooth proportions. So the patient who wants an attractive smile, we may need to undertake some additional procedures. And again, before and after photographs to help show what we can achieve and that the treatment process is worth the cost and the inconvenience and discomfort from having the treatment. Medico-legally, photos, how can we put this, can cut to the chase. We can simply show a photo, here's the problem. So no writing pages and pages of letters, show the photo, job done. So again, white spots, demineralization. Sometimes things go wrong. So here we can see an upper lateral incisor that is discolored. One of the problems of orthodontic treatment is devitalization. So we can show the patient, and we could possibly put this photograph into consent, because some patients are visual. They don't like to read. I don't like to read the instruction book. I like to look at pictures. So again, help explain what can happen and what it would look like. And obviously, the last reason for taking images would be for marketing. And these are taken from Ormco, and they show the attractive smiles. And many cosmetic dentists, as we know, will send the patient to a photography studio to have their makeup and their hair done, and then they show a very plain picture beforehand and a very glamorous picture after, trying to sell the treatment, you know, how much you can improve your lifestyle by having your teeth corrected. So, why digital? I must admit, these days it's all digital. When I was training, we were still using 35mm slides. This photo was taken from Wild Waddy Water Park, and I was at the top of a water slide, hanging out of the tower, trying to get the birch in the middle of the viewfinder, parallel with the long axis. And this is how your thinking will progress the more and more photographs you'll take. Like we've said, it will seep into your personal snaps, and you'll start looking for parallelism, framing the picture, all sorts of little tricks to give you a good picture. Now, the beauty of digital is there's no filing cabinets. We used to have rooms full of 35mm slides. These days, it's all been replaced by a portable hard drive. Simple. But there are other advantages. When we used the 35mm film, we didn't get the images back for 2 weeks. Then it was too late, because often, you know, the patient or the nurse may have had the photo, so their finger in the image, or they may have had a bit of food stuck on the tooth which you didn't see. So with digital, you can see it immediately and retake that image straight away, and there's no processing costs. It's also extremely convenient to duplicate the images, so you can give the patients before and after. So the patients can give these or show them to their friends, and then these patients become your unpaid marketing force. And also, duplication makes it easy to refer those patients that need to see a colleague. To some degree, there is a move at the moment to some cosmetic areas to use iPhones for taking photographs. The 7 megapixel camera on the iPhone does a reasonable job, but there's something special about a 35mm digital SLR with a macro lens and ring flash. It just seems to give that extra, how can I put it, authority or competence. Because at the end of the day, you've got to try and get the patient to trust you. And trust can be based on the quality of the surrounding environment, fixtures and fittings and equipment. If you've got a very run down or shabby clinic or office, the patient's probably more reluctant to buy treatment from you than if you have a very pristine, well kept, well maintained with good equipment. So it does help reflect in the standard of your treatment. Now, technical terms. I'm going to try and keep this quite simple. The terms we need to talk about are exposure. So that's a combination of the shutter and the aperture. So exposure is how much light enters the camera, and that is governed by the size of the hole and how quickly, how can we put it, shutter or eyelid blinks. We need to talk about focal depth, how much of the image is in focus. Ideally we want all the image in focus, not just the front teeth. Macro, how close can we go? White balance. We're genetically programmed to look and assume what is white and what isn't white. The camera isn't. You could actually program the camera to recognize red as white. White balance is important from that, but also the lighting. Different lighting emits different hues and colours, and white objects reflect light. So if you have, for example, LED lighting, it tends to have a bluish tinge. So we need to tell the camera what is white. ISO, this goes back to the old days of film, and the size or the grain on the film. And obviously we'll touch on file types, whether this be JPEG, TIFF or RAW. So let's return to exposure. And the easiest way of explaining this is to think of your eye. The shutter, which is the thing that clicks when you press the button, is the blink. And the size of the aperture, or your pupil, governs how much light comes in. So when we combine the shutter with the aperture, we can govern how much light enters the camera and is recorded, and whether the image looks dark or light. And by altering these two, we can get the perfect exposure. However, we've got to also factor in the flash, because these days the flash can emit various amounts of light. So actually we've got three means of control of gaining the perfect exposure. Okay, let's just think about a picture is a little bit dark. How can we make it lighter? Well, we could keep the shutter open for longer. That would let more light in. Okay, but the problem with keeping the shutter open for longer is that you've got to remain very still. So we might get camera shake. Camera shake results in blurring. So having a quick shutter speed can result in a much sharper image, but it may be a little bit dark. So how can we alter that? Well, one way is to alter the hole, the size of the hole, the aperture. Have it bigger, a big hole. Now this is a little bit confusing because a big hole has a small number. So F, which is the shutter, F is the aperture stop number. F2.8 is a much bigger hole than F22. Confusing, yes, but once you get your head around it, it's fine. The trouble with a F2.8, for example, large hole, lots of light, but it affects the depth of field, how much is in focus. So for intraoral shots, really we don't want anything less than F22. We want F22 up to say F36. Now, combining the F with the shutter still may not be enough, so you may need to alter the flash to get the perfect exposure. So just to recap, aperture is the f stop, a small f number, f2.8, has a much bigger hole to let more light in than f11. However, f11 will have a greater depth of field. When you use f11, you will need to have a slower shutter to let more light in than you would with f2.8. If you have a slower shutter, you may get more camera shake and blurring, so you may need to alter the output of the flash. So hopefully that is all clear now. Here we can see what's not clear, depth of field. So in the middle of the image it's clear, behind is blurred, in front is blurred. Clinically we can see the incisors are clear, but the molars are blurred. How do we improve it? We improve it by increasing the f-stop number, so f22 like we've mentioned. When we go to f22, the aperture gets smaller, we get less light in, the image becomes dark, we need to adjust the shutter, we make the shutter slower, let more light in, camera shake possibly, adjust the flash. So by altering these three, we blend them together to get a nice clinical image. So like we said, this image looks too dark. What are you going to do? Make the shutter slower to allow more light, but careful with camera shake. Or make the aperture a smaller number, so the hole becomes bigger, but the depth of field is compromised. Or alter the output from the flash gun. Now, white balance, like we said, we are conditioned to recognise white. The camera is just a mechanical object. It's got to be told what is white. White is the light reflected, or the wavelengths reflected off the surface, so it is dependent upon the light shining upon it. And this is important because if you use a dental light, for example, your pictures will be an orangey tinge. LED light has a bluish tinge. And so, although the camera does have a preset, factory set automatic white, it is best to set it to either flash or calibrate it yourself. To try and illustrate what is white and what is not white and how it differs from camera to camera, this was taken on a Canon with the white balance set to flash. Here, the Canon, we altered the white balance set to automatic this time. And you can see the difference. So, depending what ambient light you have in your surgery, I suggest you set the camera and take 2 photos, one on automatic, one on flash, and decide which is the best for you. Now, flash, so the white balance can affect the colour, which is not so important for orthodontics, but it is for restorative and cosmetic dentistry. So there are lights, instead of a ring flash, which attach to your camera. A POV, for example, from Optident. And this gives light at 5,500 Kelvin, and it's what the lab technicians use to help determine shade. So if you're doing lots of restorative dentistry, this may be an option for you. ISO. ISO is the grain or the size of the particles on the film. So when you had a high ISO number, the film was very sensitive to light. So if you were taking photographs in a dark environment, you may have an ISO of 800. This meant the camera needed less light, so it wasn't reliant upon the flash as much to get a picture. However, the film became very particular or grainy. So ideally, ISO 200. These days, most of the cameras are set to ISO 200 for good quality images that aren't too pixelated. You can set it to ISO 100, but the flash will need to give out twice as much light as it does with ISO 200. So to save your camera batteries and to save constantly having to recharge the batteries, I would suggest set it to ISO 200 and you will still achieve a good image. File types, the main ones are RAW. These are very large files, maybe 5-8 megabytes, that take up a lot of memory. If you're doing some cosmetic work, for example, trying to gain membership of the British Association of Cosmetic Dentists, you need to submit RAW files because they cannot be altered. Most people store their images as JPEG. However, you have to be careful that every time you save a JPEG, so if you alter it and then save it, it reduces the quality of it. A file that doesn't undergo this is TIFF. So TIFF, we can adjust it like JPEG, but there's no loss of detail like RAW. And the memory requirements of a TIFF is between that of the JPEG and the RAW. And one word of warning is if you use a computer for office management, what we've started having to do is to resize our images because the camera takes a 20 megapixel picture, which takes up a lot of memory, which you can't see the detail on a computer screen. So basically we have an external hard drive where we store the patient's RAW file and the large JPEG taken on the camera. We then resize the JPEG and export it and then place that into the practice management software so it doesn't clog up the system and mean we're having to continually buy more RAM and hard drives for the server every couple of years. Like we said, most computers are 1024 and across, so that's fine for your Keynote or PowerPoints. So, what equipment do you need? Quite simple: a digital SLR camera, a ring flash, and a macro lens. Simple as that. There are compact cameras which can take intraoral photographs, but if you want a true point-and-shoot system that is quick and easy to use, go for the digital SLR, ring flash and macro lens. These days, like we've mentioned, the sensors on the camera are recording more and more information, so we're up to 20-25 megapixels. We don't actually need all that detail because we can't see it. So if you can buy one of the older digital SLRs, such as a Canon D400, Nikon D40, that'll be fine. You don't need the latest all singing, all dancing one. Also, there's the difference between a professional camera and one for the beginner. And basically the difference is in the build quality and the weight, or what the camera is made out of. So the beginner may be plastic, whereas the professional is metal, a lot heavier, and the mechanisms within the camera, for example the shutter, will take or work a lot more times than that of the beginner. But to be honest, I've just bought a D700 and it's fantastic. I have no problems for it. I'm not really a total camera photography enthusiast, so I don't see any advantage in paying for a D7 or a D5. The other difference between the professional and the beginner is the size of the sensor which records the image. The old-fashioned film-based cameras were 35mm because that's how big the film was that was exposed for each image. So in the professional camera, that is also 35mm. But in the cheaper cameras, they've cropped it so it doesn't record quite as much. And this image was taken from one of the digital photography sites to show or to illustrate what is recorded on a professional camera, 35mm film equivalent, and a cropped sensor. To be honest, for our use, there's not a lot of difference. So again, if you're a keen photographer, treat yourself, buy an expensive one. If you're just using it for clinical work, just get the beginner's one. The ring flash. People often ask, why can't we use the flash on the camera? The reason is shadow. So as we can see here, we've got a set of study models to illustrate the patient's teeth. Macro, close up. The camera is close to the teeth because we're using a macro lens. And we can see how the light is divergent from the camera flash. And this divergent light doesn't actually touch or fall upon the teeth. So it's no good. So this is the reason why we need to use a ring flash, so we can get well illuminated photographs. However, with a ring flash, when it comes to do facial photos, we can get a lot of shadowing, and it can also flatten the face. So to help overcome that, you can either use the camera's normal flash, or you can buy a double flash, a combination of a ring flash with a separate point flash when you simply switch between the two. And whilst we're on about illumination, don't forget, for those doing a lot of restorative cosmetic, you can get the POV lights which emit natural daylight. Next we come to the macro lens. Ideally I would suggest a 100 or 105 macro lens because it allows us to get very close and pick up a lot of detail. The old days, so if you use a smaller, like a 50mm macro lens, you can't capture as much detail. In the old days you used to try and crop or zoom in, and because it was only a 1 or 2 megapixel camera, if you zoomed in too much, it became a very pixelated, grainy picture. With the 20 megapixel cameras, it's not such an issue when you zoom or crop. And like I say, the beauty of a macro lens is that you can get very close and almost take a single tooth. The macro lenses are expensive. You can buy Nikon or Canon own brand. Cheaper alternatives are available, such as Sigma or Tokina, but you do have to ensure that these cheaper ones are compatible, because the electronics are slightly different between Nikon and Canon. And the flash settings, this is a manual flash, so we've placed some adhesive labels onto the flash so that we know the close-up work aperture is f22 because we want depth of field. Shutter is 1/500th and the flash is on quarter power. Magnification. On the macro lens, there is a scale which represents magnification. Turning the lens alters this. Turning the lens also helps focus the camera. This is wrong. You always turn the lens to set the magnification, and then to focus, you move. You move backwards or you move forwards until the image is in focus. You do not turn the lens. The reason for this is that we want all our images to be of the same magnification, because then we can compare. If you turn the lens, you've lost it. So set the lens to the correct magnification and then focus by physically moving yourself backwards or forwards. Like we've mentioned, there are compact cameras and they are getting a bit more technical and a bit better for intraoral use, but we've still got the issues of light, and they can't have a ring flash, so you have all these LED attachments. The LEDs emit a blue tinge, so you have to set the white balance. Often you can't have a manual focus, so the magnification's wrong. It's possible, but it's not worth the hassle. And we've mentioned before the POVs. So you've got the camera, you've got the lens, you've got the flash. What else do you have to buy? Well, possibly a card reader. This was a compact flash. You have to train your staff well, because the compact flash has lots of pins and a heavy-handed assistant can bend them. So these days you can buy, for example, an iFi card or Transcend card, which will wirelessly beam the images to your computer. So you can send the pictures over your Wi-Fi, so you don't need card readers. Retractors are needed. So for cheek retractors, I like a slightly elongated C shape. And to hold the lips for my occlusal images, a horseshoe. Mirrors are important. Some people like to use them for buccal shots. To be honest, I tend to take those directly, but I do use mirrors for palatal or occlusal shots, and there are various types. I would tend to stick to the glass ones because they don't scratch as much as the metal. Mirrors with handles are great because it helps keep your fingers out the way, and it helps positioning the mirror correctly within the mouth. And contrasters. These help create a nice background so there's no tongue in the way. So here we can see the lower incisors with a uniform black background, so we can pick up quite easily the incisal edge morphology. Another accessory you may wish to consider if you're doing a lot of restorative work, is a polarization unit, basically to filter out the light so you don't get this specular reflection. The specular reflection is the very white bits, very glossy bits. So it helps with the shade and it helps with the surface texture. And here we can see the two, and this is taken from the Polarize website, and this is the attachment. So it filters the light as it leaves the flash, and it filters the light entering back into the camera, helping reduce the reflection. The unusual bit of equipment might be a step, because as we'll see in a minute, the height or the position of yourself is important when taking images. So once you've got your equipment and you've got your camera, you need to calibrate it. So set it to manual, put it on ISO 200, put the white balance to flash, and then set the shutter, set the aperture, and take some photos and see what happens. If they're too dark, reduce the shutter speed. For example, from 500th to 1/250th. Don't alter the aperture number. If they're too white, maybe increase the aperture number from f22 to f36, which will reduce the light and still give you an excellent depth of field. Or alter the camera, so the flash output on the camera, maybe to 1/4. I mentioned the white balance, and it's basically working through these until you get an image that you feel satisfactory. The latest cameras, though, have very good ETTL. ETTL is electronic through the lens metering. Before, your teeth reflect a lot of light and used to confuse the camera. It's too much light entering it. These days, with the better electronics, it's much better. So you could probably just set your camera to f22, 1/250th for the shutter, and take the pictures, and the camera will calculate how much light you need and the flash output itself. So my old camera, which is totally manual, I write the settings down. For my new one, which is totally electronic, so totally automatic, I have it on f22 1/200th for intraoral and f6.3 1/200th for extraoral, and let the flash do its stuff. So apart from taking pictures of patients, we can take photos of study models. These days, with the advent of scanning, probably not quite as needed, although if you want some help with treatment planning, taking some easy or quick photographs of study models, which then can be emailed to a colleague, it's a lot easier than trying to send a large STL file. Again, radiographs, taking photos of radiographs, and what I do for this is simply put the camera on automatic, turn off the flash, put the image onto a light box, and try and fill the viewfinder. But again, the move to digital, we tend not to see as many film-based radiographs. And then some slightly different photographs for beauty treatments. So this is a patient I've treated with some fillers to show the difference before and after. Now, just to round off, a few hints and tips. First, avoid black background clutter. So this was when we were doing a course in Venice. Very beautiful, very nice picture I took. But there's a crane in the background. And unfortunately, I can't do anything about that. So when you're taking photos of your patient, make sure there's no background clutter, like the soap dispenser. This image, other problems are the camera is the wrong way around. It needs reorientation into portrait as opposed to landscape. And we can see the shadow. Some digital SLR cameras, you can have the option of a viewfinder with a grid in it. These can be very helpful because it can help get the occlusal plane parallel through the middle and, for example, the canine in the middle of the image. So this can be helpful. We've mentioned about magnification. You turn the lens to the desired magnification and then you move to focus. Height can be a problem, so if your chair doesn't move up or down, you may have to put the patient on a normal chair as opposed to the dental chair, or you may have to stand on a box or bend your knees. So here we can see in this image we're too low down because we're looking up at the patient. So this could be a very tall patient or a very small operator. Shadows. Ways of overcoming shadows are to have a black background, so not a white wall but some felt on the wall. A point flash, single point flash, so either the camera's flash or, like we saw earlier, the double flash, or simply set the ring flash to emit light from one side only. So here we can see the shadows, which have been eliminated by simply resetting the flash to allow it just to emit light from the right hand side only. Other problems: try and create a symmetrical image, make sure the occlusal plane is level and that you're parallel. What do I mean? Well, here we're too far forward. We're not perpendicular to the teeth. We need to swing the camera distally, so the patients may need to pull harder on the cheek retractors. Once we've achieved that, we don't want to be looking up or down, as can be seen here. We need to be parallel with the occlusal plane, not like this. So this sort of photo would be perfectly acceptable. Here we can see we're stood to the right of the patient and we're not in focus because we've got the wrong angulation of the mirror and we've got some blurring. This is much better, but we need to alter the magnification and we need to either warm the mirror or have our assistant blow some air onto the mirror to stop the steaming, and then we could see the second molars, because here we can't. And again, no second molars, so the mirror isn't far enough back and there's no lip retractor. Again, we're too far to the right and we're not symmetrical because we can't see the first molar, and the patient is breathing, which is a major inconvenience when taking photographs. Another problem for restorative guys is this specular reflection, these shiny bits. This patient has very smooth teeth through erosion, but younger patients with their tertiary anatomy of the enamel we can't see. So how can we avoid this? We've already mentioned polarization. Another option is to have a flash where we can move the units further apart so the light isn't quite as direct. Or take another picture, this time up, so the light is bounced or reflected upwards. So again, it's to give the technician an idea of the texture of the teeth. And then another trick is to go to black and white, because this will help determine not only the value, the texture, but also the surface luster. So, thank you for your attention, and I hope this brief whistle-stop tour of digital photography will help. There's a lot more to learn with digital photography, but hopefully this will be sufficient to get you started and to allow you to take good digital photographs which are clinically relevant and help both sell treatment to your patients and to help you develop, because looking back at your pictures at the work you've done is one of the best ways I found of learning. So thanks for your attention, and hopefully see you soon. Thank you.